صباح الخير. I'm Zainab Al-Talal. I'm currently a gynecologist working in National Guard, King Abdulaziz Hospital, and then National Guard Hassa. It gives me great pleasure presenting today as a part of gynecology group, Saudi Gynecology Group. I want to thank Dr. Khalid Said and Dr. Nisreen and the whole group. Well, I was asked to do a presentation about ovarian cancer prevention. It's very simple. The answer is very simple. It's no. Okay, there's no means of prevention, at least talking up to date. So I think everybody knows that ovarian cancer is not one disease. It's a heterogeneous disease, and there is no like a good screening method for ovarian cancer, and you know it's a very rare disease. It's not as common as endometrium. Well, we'll start. Whatever. Okay. All right. Well, we start. So we know that ovarian cancer is the most common, frequently cause of death among gynecological cancer in developed countries. And the incidence is usually less than 2% in general population. We know cancer in general is a disease of aging population. Usually it's not the disease of young, it's a disease of aging population. Well, there was a large-scale, prospective clinical screening trial that showed that screening is no good, actually. It doesn't diagnose the cancer in early stage. It causes a lot of psychological disturbance to the patient. There's a general consensus that we don't screen average risk women. But there was a questionnaire across the U.S. gynecologists, and they were asked, general gynecologists, they were asked would they screen an average risk women. They said yes. Every three general gynecologists, they will screen. One of them will screen an average risk woman. There is a recent talk about the type of ovarian cancer. Now we have type 1 and type 2, like the endometrium. Type 1, which is, we always talk about type 2, which is the most common type. But type 1, which is the less aggressive, they say, which is the endometrioid, the clear cell carcinoma. These are the type 1, and they usually are slow progressing. The other type is the type 2, which is the aggressive tumor. We usually see it in our clinical practice, which is a most common type, which is a high-grade COPAP tumor. So one of the more important findings in the last decade of gynecological oncology confirmed the theory that type 2 derives from epithelium of the fallopian tube. It was a breakthrough, actually, from the fallopian tube, whereas a clear cell carcinoma and endometrioid derived from endometrial tissue that migrate retrograde menstruation. What are the risk factors for ovarian cancer? Age as one. We know it's a common cancer in between the age of 50 and 59. The other risk factors is familial ovarian cancer syndrome / family history of ovarian cancer. We know both are different. Familial ovarian cancer syndrome is only it takes only 10% of an ovarian cancer population. Usually there is a strong family history of ovarian cancer, but it can be masked by small size families. We know that the risk of ovarian cancer and the familial ovarian cancers in BRCA between 25 and 50%, and in Lynch is around 14%. Family history of ovarian cancer. If you have one family member with ovarian cancer, that will increase your risk from the general population, which is 1.2% to almost 5%. But if you have a second family member with the same thing, you will have almost 7% risk of having an ovarian cancer. The other risk factor is infertility, nulliparity, low parity, also endometriosis, perimenopausal or postmenopausal hormone therapy. Recently there was a lot of talk about the HRT and the risk of and the risk of ovarian cancer. Now there are so many people, they stop giving HRT because of the risk of ovarian cancer. Risk and benefit of screening. The potential benefit of screening is to identify the disease when it's early stage and curable, which till now we cannot identify. In screening we don't have a good positive predictive value, so most of our screening, they will put the patient at risk of having an intervention, surgery, what have you, increase the psychological impact on the patient too. Although ovarian cancer is an important cause of death, the prevalence in general population is low. So the problem for false positive screening, it's a critical issue about ovarian cancer. So can ovarian cancer be prevented? Well, we'll see. Before talking about prevention of ovarian cancer, I would like to bring the theories or hypotheses of ovarian cancer. One of the common ones is the continuous ovulation hypothesis. It means that if the lady has started an early menarche, late menopause, it means that she's been ovulating for so long. And you know, with ovulating so long, there is a lot of the surface epithelium of the ovary. You will have proliferation and repair, and this process will go on and on and on. And we know that with continuous repair, there must be a mistake that eventually will lead to cancer. The other hypothesis is the pituitary gonadotrophins hypothesis. It says that whenever we have a high FSH and LH, the patient is at risk of having an ovarian cancer, in the sense that high level of circulating FSH and LH produce more estrogen or estrogen precursors, which stimulate ovarian surface epithelium, same thing, proliferation, and then that will cause a malignant transformation. Usually any active cells will end up by malignant changes. The other hypothesis is inflammation hypothesis. Ovarian cancer can be explained by the other hypothesis if the patient has a early menarche, late menopause, due to then we'll talk about ovulation, injury, and repair. But some risk factor for cancer cannot be explained, and the inflammation hypothesis can explain that, especially in patients with talc exposure, which is very rare we see nowadays, tubal ligation and hysterectomy. We always say that tubal ligation and hysterectomy is actually a protective against ovarian cancer, because you know all the toxins from the lower genital tract will not be transmitted to the upper to the ovary through the tube and uterus. Other medical condition that causes inflammation, which is endometriosis, PID, it's also considered as a risk of ovarian cancer. There's other hypothesis, which is androgen progesterone hypothesis. They always say that continuous ovulation, the ovarian tissue, especially the theca cell, they will produce androgen, and we know that it was linked somehow to the ovarian cancer. And we know in the postmenopausal state, the ovaries and androgen are actually androgenic. And it was linked by that time, for ovarian cancer risk. The other one is the same thing, the ovarian stromal hyperactivity hypothesis. It says it's all about the estrogen production in the ovary. Then this is the very important theory, which most of the people believe, where most of the ovarian cancer started from the stick. Stick is the detection, it was discovered by the detection of pre-malignant cells in the epithelium of fallopian tube, especially in the fimbria. And that has resulted in a revolutionary theory regarding the origin of epithelial ovarian cancer. The serous tubal intraepithelial carcinoma had been detected it was detected in the patient with BRCA1 and 2. after extensive slicing and specimens from the patient for BRCA1 or 2. So they're considered most likely to be precursor of a high-grade serous ovarian cancer, which is the most common pathological histological subtype. The incidence of stick detection for fallopian tube specimen, it was 2 to 7%, in the patient underwent risk-reducing salpingo oophorectomy for a patient with BRCA1 or 2 mutation. It's up to 80% of a patient with BRCA1 and 2 and diagnosed with a high-grade serous epithelial cancer, and it was almost 50% in a patient with sporadic ovarian cancer. One might ask, does all ovarian cancer originate from the fimbria? The answer is no, for the time being, because there was a strong association, but not all sporadic ovarian cancer they had a stick in their fimbria. Maybe in the coming years, yes, but for now, no. Well, so what can we do to reduce this risk or to prevent the disease? The most common thing that we used to do a BSO, and now we are going toward the salpingectomy. BSO is definite if a patient has a documented BRCA1 and 2 mutation or LENG, so you can do a BSO. But salpingectomy now, it's in fashion, especially for the general gynecologist, where they do a hysterectomy for benign diseases. So we call it now opportunistic salpingectomy. So whenever you do a hysterectomy for benign disease, and that's the message I want to give for all my general gynecology colleagues, that whenever you do a hysterectomy for benign disease, it's very good idea to remove the tubes of those ladies. So preservation, because we all know that preservation of the ovarian function is very important for the lady, and for both premenstrual and postmenopausal, premenopausal and postmenopausal lady. We know that even postmenopausal ovaries, they still secrete some androgen, which is good for the patient bones and general health and psychological, I don't know what. So ovaries are usually very important in the premenopausal and postmenopausal ladies. So surgical menopause, we all know this, that increases the risk of psychosexual, cognitive, cardiovascular dysfunction, and the incidence of fatal and non-fatal MIs. So according to the existing, there was an issue also after the salpingectomy became fashion for all the gynecologists. We have another issue, which is they said that salpingectomy might actually increase the risk of having a premature menopause by just changing the blood supply to the ovary. But up to date, according to the data, there is no solid evidence for that. So bilateral salpingectomy with ovarian preservation should be considered as the best preventive strategy for women with a low risk ovarian cancer, not for, of course, for BSA. We talk about chemoprevention. The most common chemoprevention we know is OCPs. So women who use OCP for 5 years, they usually have almost a 50% protection against ovarian cancer. We always talk about OCPs, but I don't hear a lot of people talking about progestogens. Actually, progestogens were progestin-only pills. They don't suppress ovulation, but they're as protective as combined estrogen and progesterone formulation. The other thing about the progestogens, they found out, because we used to give in a postmenopausal lady, if the uterus is out, we used to give them estrogen-only pills. But they actually now recommending, even if the patient does not have a uterus, we should give her a combined HRT, estrogen progesterone, because they found that actually progesterone is actually kind of protective for ovarian cancer. The other chemopreventive method, which is metformin. Metformin also is in fashion now for endometrial cancer, for endometrial hyperplasia, and now also in ovarian cancer. It was discovered that it has a strong antineoplastic effect in several cancer. It activated the MAP activated protein kinase, and which is a critical energy sensing pathway in the cells. So it has a favorable effect as adjuvant treatment or preventive treatment, but there is nothing solid about it yet. The other thing, NSAIDs. Aspirin was in fashion, I think, for some time, but for prevention of ovarian cancer, but there is no strong evidence for it. So NSAIDs, the COX-2 inhibitors are a class of NSAIDs where activity against tumor development has been suggested for cancer of the ovary, colon, breast, lung, and cervix. It basically only lowers the level of VEGF, which is an important thing in cancer development. The other things, which is retinol, vitamin A, vitamin D, they're all like antioxidants, which can reduce your chances of ovarian cancer. So they all influence cell differentiation, proliferation, apoptosis, and an important physiological role in a wide range of biological process. Green tea. It's always like in our daily life. We always mention green tea to our patients. Green tea has a specific material in it that can work as an antioxidant and show the promising properties, such capacity to decrease expression and activity of a large spectrum of cancer-related proteins. Last thing, be active. Patient physical activity, it was compared to obesity. We know that obesity can increase your chances of cancer obesity can increase your chances of cancer. And BMI was a well-documented risk factor for many cancers. Moderate intensity physical activity also decreases cancer risk by blunting chronic inflammation and enhancing immune response. The most probable mechanism is linking with cancer risk and survival include decreased body fat. When you have less body fat, you have less estrogen. Altered reproductive hormone levels, cytokines, growth factor, and change in immune function. So it was suggested as a mean of a preventive measure, but it's same thing. It's all observational studies. There is nothing documented. So by the end, thanks for everyone. Thank you.